Good morning, good afternoon, good evening, students. Welcome to the fourth topic in Capstone, which is fatigue. So the objectives are that we should be able to list differential diagnosis for fatigue across the systems. We should be able to evaluate a patient with fatigue using 4 steps of epilogical approach. We should be able to order appropriate labs and imaging after evaluation. And finally, we should be able to recommend appropriate treatment based upon the diagnosis. So as you can see, fatigue spans across the systems. For the purpose of this discussion and for the topic in cases, we will address only chronic causes of fatigue or causes of fatigue that cause chronic fatigue. So we're not addressing acute fatigue or fatigue that is really short duration, because that is usually self-limited. So you can see that people can have sleep disorders, anemia, then endocrine problems, and a whole lot of them. And then we have chronic liver disease, renal failure, and heart failure. And then we have connective tissue disorders. People can have malignancy. They can show up with fatigue. People can use some drugs or medications. Then infections can cause fatigue, and then finally psychogenic causes can cause fatigue as well. So let's look at all of them individually. So here is the table that has really just the most common causes of fatigue, and there are of course more than this, but for the purpose of this discussion we're just using these. There are some that are quite obvious. For example, pregnancy can do it too, deconditioning can cause chronic fatigue too, but just for diagnostic purposes I'm just using these most common examples. So you can see the high yield features or high yield findings in all of these problems are listed here on this table, and then we'll of course talk about each one of them individually in this talk. So people with poor sleep hygiene, with a simple sleep questionnaire we can find out that this is a problem. People who have sleep apnea, we can find out that okay, if they might be snoring, they may be overweight. People with hypothyroidism usually have cold intolerance and then many other symptoms of thyroid problem. And then people who just have hyperglycemia, they can have any of the symptoms ranging from bones, stones, moans, and groans. People with diabetes insipidus and mellitus will initially have polyuria and polydipsia. With mellitus, people can have polyphagia as well, and then that's how this gives us some clue in the history. Adrenal insufficiency patients usually have low blood pressures, and then there are some other features too. People who develop Cushing disease or Cushing syndrome, they have very remarkable moon face and buffalo hump, and then some of the other features. And people with hyperaldosteronism usually have very resistant hypertension, and when you do their labs, they have high potassium levels. Chronic liver, kidney, and heart disease patients usually have swelling and dyspnea. So that's how you know that they have some sort of problem going on that is resulting in many other symptoms as well. And these people may actually present with different problems and different chief complaints other than fatigue, just like all the other diagnoses too, but sometimes they just have fatigue. So people with anemia, they might show some symptoms of blood loss when you take their history and you ask them really high yield questions about blood loss, and they'll give you a positive answer. They may have a family history of certain kinds of anemias, and that's how you figure out. People with occult malignancy who don't really have any features of cancer anywhere in the body, and they haven't really started to lose weight, they may just they have started to lose weight, they may just come along with the weight loss, they may say they have fatigue, and when you ask more questions, maybe you'll get the diagnosis. People with connective tissue disorders, which most common of them are your rheumatoid arthritis and lupus, will have arthralgias and myalgias. Fibromyalgia, strictly speaking, is not a connective tissue disorder, but it kind of falls in under the same umbrella, and we'll talk more about some of the other symptoms of fibromyalgia. Some chronic infections will present with fatigue. They may have fever, they may also have some localized symptoms, and we'll talk about that. A lot of medications can cause fatigue, and a whole lot of, especially elderly populations, suffer from polypharmacy. They just take a whole bunch of medicines. A lot of them are usually unnecessary, and then it ends up causing fatigue. And then in order to relieve symptoms or side effects of one medicine, more prescriptions are given, unfortunately. And then psychogenic causes of fatigue are going to be there too. So people with depression will present along with the fatigue as well. So these are just some of the very high level findings. And then of course we'll talk about each one of them individually, and we'll figure out how to distinguish one from the other and work up the patient. And of course, like I said, obvious causes are there too. So let's look at the first, sleep disorders. So the symptoms of and signs in addition to fatigue would be that people may just let you know that they are not sleeping very much at all, or they have interrupted sleep. They can also, if you ask them, they'll let you know that they snore at night, or they stop breathing at night. These top 4 symptoms are usually the main symptoms that people present with, or when you ask them, these are going to be positive more likely than not. The rest of the symptoms are not going to be necessarily there. So if your patient says no to all of the 4 top symptoms, then don't just keep going down the list and ask all the very uncommon features, because it's not going to really help you with the diagnosis. So if they say yes to the top 4 symptoms, then you can go ahead and ask the rest of the symptoms too. And you can see they can have vivid dreams, morning headaches because of the apnea during night. Then they also can't concentrate during the day, which a lot of people can't anyway. Their physical features may point in this direction too. For example, they may be overweight, they may have a large neck. When you examine them, they have small mandible, tonsillar hyperplasia, and you can, based upon their, looks and their habit, the lifestyle, you can get some clues that, okay, maybe this is sleep disorders. And you can see that the duration of sleep and interrupted sleep, these 2 things will basically point toward insufficient sleep hygiene. So these people don't necessarily have sleep apnea. This is relatively an easier problem to deal with. They just are not sleeping right. They have a poor sleep hygiene. So the treatment would be, of course, patient education, the first thing, and then you can prescribe some medicines as well if needed. People with the rest of the symptoms, if they have everything below this point, then you're going to start looking for sleep apnea, and then you can order a sleep study. If apnea-hypopnea index is more than 30, then of course the diagnosis is done, and then their treatment would be starting with weight loss, lifestyle changes, and CPAP machine. They can also go for surgery. And it is important to treat it, because it's not just a matter of poor quality of life, it's also a matter of complications that can arise from sleep apnea, which can be pretty bad. So for example, people can develop pulmonary hypertension, right-sided failure, cor pulmonale, and there have been some studies recently that show that people with sleep apnea are more likely to develop diabetes later on in life. And then chronic hypercapnia and polycythemia are not the best things to deal with either. Next is our thyroid disorder. So people who have especially hypothyroidism, they will have fatigue, and this, I'm sure you're very familiar with this topic. Additional symptoms and signs would be that they have cold intolerance, weight gain, constipation, dry skin. Female patients have a lot of heavy bleeding. They may be depressed also. That's why everybody who is depressed should get their TSH levels checked. It's extremely important. It's a very common diagnosis. People can have some cognitive impairments or some delayed mentation. They also have some of the physical exam findings when you examine them. So they may have bradycardia and maybe slightly lower blood pressures. They may have goiter on exam. This is not always present. Myxedema, usually in the severe cases only, and they may have some delayed reflexes if you check their reflexes. So again, you can see the top 3 or 4 features. If present in history, then of course definitely look for the physical exam findings down here. But all of these are not going to be necessarily present. For example, people may or may not have bradycardia. A whole lot of people have just essential hypertension in the population. So your patient with hypothyroidism may just have hypertension in itself, so they may not show with hypertension. So absence of hypertension doesn't mean that you rule out hypothyroidism. Also, people usually don't have goiter, so absence of goiter doesn't mean that you rule out hypothyroidism. Myxedema is a very late finding, so it's not going to be present and 90+% of the time. Reflexes also may not be delayed all the time. So you can see that most of your diagnosis will rest upon the history features. So that's how you will approach the patient. And then if you are suspecting it, then of course you will draw the TSH levels, the T4, levels, and then this will give you the idea, and you can make your diagnosis based upon this lab TSH here. Thyroid peroxidase antibodies are not required to make the diagnosis of hypothyroidism, but if you do draw them and they're positive, then the patient obviously has Hashimoto thyroid. And then these are just the primary causes of these labs are present only in the primary hypothyroidism. Then people can also have central hypothyroidism, and you already know this. They will have low TSH level. If a patient has low TSH, then usually we think about hyperthyroidism. But if the patient has symptoms of hypothyroidism and you're seeing a low TSH as opposed to high, then definitely think about central hypothyroidism. And then they may have high or low TRH. If the problem is in the pituitary, then TRH will be high. But if it's in the hypothalamus, then of course TRH will be low. So that's how you will get to the final diagnosis. Treatment, of course, for hypothyroidism will be thyroid supplements. There are lots of different forms available in the market, so we can prescribe them. Complications are many for hypothyroidism, so therefore it's extremely important to treat it. The most grave complications are cardiovascular. People can get atrial fibrillation, and they can also go into thyroid coma if they have mixed edema thyroid. And then here one quick thing about Sheehan syndrome. I'm sure you're all very familiar with it. You reviewed it in your repro. It's usually an obstetric postpartum complication when people have postpartum hemorrhage and they bleed a lot during delivery. It can lead to pituitary necrosis, and then this can cause hypothyroidism or panhypopituitarism. So they have a whole lot of they end up with hypothyroidism because they had pituitary necrosis, and then their levels will look like something like this: low TSH and high TRH. This is called Sheehan syndrome. So just remember that. People can also get trauma and tumor in the pituitary gland or in the hypothalamic area, and that's how these things can cause central hypothyroidism. And then some autoimmune disorders can also cause it. Here is just a quick loop to review the feedback mechanism, so you can see that TSH is going to act upon thyroid gland, and this is basically the center of the activity, and this is where the T3 and T4 will be released through negative feedback. They will go back to the hypothalamus, where TRH will be suppressed with T3, T4 if there is too much of it, but if there is not enough, then TRH will be released, which will act upon anterior pituitary, and that will release TSH. So you can see in the case of primary hypothyroidism or just regular hypothyroidism where the problem is in the gland, for that reason TSH and TRH will be high. But when the problem is in the pituitary, then TSH will be low as well, and if it's in the hypothalamus, TRH will be also low. Here is goiter, so you can see that there is enlargement on the front of the neck. Alright, so the next diagnosis is diabetes, and diabetes is a huge thing. It's not just a disease, it's a syndrome. It's an epidemic these days. A huge population is suffering from diabetes, so it's important to be familiar with it for that reason as well. But people can just come in with fatigue. They don't necessarily have to have symptoms of polyuria and polydipsia and polyphagia. It's not going to be always present, so people can just come in with a very vague chief complaint of fatigue. So whenever you suspect it, based upon family history and some of the personal history features, then definitely look for it. So especially if they have any of the P symptoms, then obviously you're going to check for it. So the complications of diabetes are going to be microvascular and macrovascular complications, and you are already familiar with it: retinopathy, neuropathy, and nephropathy. Macrovascular is going to be your atherosclerosis and cerebrovascular accidents. So in order to prevent these complications, again, it is extremely important to diagnose it and manage it properly. The diagnostic test would be your hemoglobin A1C and metabolic panel. Hemoglobin A1C has become more and more of a standard test, so we are performing it more often than the glucose tolerance test, and it's once you make the diagnosis, of course, you will start with the treatment. The treatment will basically depend upon diet and exercise. There is a huge amount of patient education that needs to go into diabetes management. Lifestyle is the bedrock of the treatment. People don't usually realize it, but with lifestyle, a lot can be accomplished with proper lifestyle for diabetes treatment. Of course, these people need to be advised to stop smoking, and then if you need to prescribe oral agents or subcutaneous medicines, and of course these are present as well. In oral agents, you have bigonides, sulfonylureas, and gliptins, and insulin can be given. And then, of course, in addition to glucose management, you will control their blood pressure and lipids. And you're all familiar with it already. This is just the principal mechanism of action for oral diabetic agents. So you can see you already know about it. I'm not going to talk about it in more detail, but basically these are just 3 or 4 different categories of medicines that will act on different parts. Here is a quick table. So bigonides, the example of this class of drug is metformin. It's the most commonly used medicine. It's probably the best medicine as far as oral agents are concerned. It's highly effective, and we can use it for polycystic ovarian syndrome also, and then also metabolic syndrome as well, because sometimes when metformin is taken, it can actually correct some of the polycystic ovarian syndrome symptoms, and people can, for example, if they have infertility, they can conceive after taking this medicine. If they have irregular periods, the periods can become regular, so they can become ovulatory. And then the metabolic syndrome patients can also benefit from this. As far as diabetes is concerned, it will work by decreasing the gluconeogenesis. So that is the principal mechanism of action for this drug, and it's really great. Sulfonylureas is another class, so that is not necessarily the first line or the first choice drug, but you have brand names glipizide and glyburide and Amaryl, and I know you are not supposed to really know the brand names, but you'll see these a lot. So basically these are the medicines, and then the principal mechanism of action would be that they increase insulin secretion. And then you have thiazolidinediones. Most of them are already taken off the market because of the side effects, but Actos still is hanging out there. So this medicine acts by principally decreasing the insulin resistance or increasing the insulin sensitivity. It can cause lower extremity swelling and exacerbate some of the symptoms of heart failure, so we don't really use it as frequently. I don't prescribe it. Sometimes people take it because this is kind of their last medicine before they need to go on to insulin, so this can be combined with some of the other drugs. But anyhow, your main ones are going to be your bigonides and sulfonylureas. Then you have insulin, of course, which is the most potent of all, but here is what can happen with insulin as well. Because insulin is an anabolic hormone, it can cause macrovascular complications. It exacerbates atherosclerosis, thereby causing some macrovascular complications. So therefore, it's not a good idea to just keep on taking insulin and not worry about diet. So the point of this is that people who have diabetes, if they keep on if they stay on the same lifestyle, don't change their diet and lifestyle, then they're not necessarily going to benefit from insulin most effectively, because they will keep on taking insulin and then finally will end up with macrovascular complications. Although their blood sugars may get controlled to some extent because they keep on pumping more and more insulin, but they will probably end up paying some sort of price. Hyperglycemia in itself can also cause macrovascular complications, and then hyperglycemia, sustained hyperglycemia, will cause a whole lot of microvascular complications. So just keep that in mind. Therefore, it is important to educate the patient about the importance of diet. The best scenario would be where they don't have to take insulin necessarily and can control their diabetes with diet and exercise and maybe some oral agents. But if they still have to take insulin, then which happens a lot, especially if people have lived with diabetes for more than a decade, then the insulin dose should be minimum. So that is a conversation that needs to happen between the patient and you. Then there is secondary type of diabetes, so diabetes due to underlying pathology. So people, you all know that if they have hemochromatosis, because of which they get bronze diabetes, so they have higher skin pigmentation, and then they also have elevated iron levels. So these are the patients who can develop diabetes because pancreas is affected by this disorder. Again, this is not going to be an obvious diagnosis. Obviously, if you see somebody who has diabetes based upon their symptoms, you check their A1C, and of course they have diabetes. How do we distinguish that from hemochromatosis? Because 95% plus patients are going to just have primary diabetes because of insulin resistance. So oftentimes we don't necessarily just by reflex check secondary causes of diabetes. So at what point should we think that, okay, maybe this patient has hemochromatosis as opposed to just regular diabetes? They are not necessarily going to have skin pigmentation, especially darker skin patients. So one way to look for this would be if you look when you draw their metabolic panel and their liver enzymes, they may be elevated. So whenever the liver enzymes are elevated, then obviously you can go ahead and check for the specifically for iron panel, and then this is how you will know that this is maybe hemochromatosis. The other thing would be that their diabetes will be quite resistant, so they may not get under control very easily. They also may not show all those signs of metabolic syndrome, so they may not be overweight, for example. They may not have hypertension and hyperlipidemia and all the other things. So there are some clues. So just the bottom line is, if there is anything a little bit out of the ordinary, and also you see some labs that make you suspect some liver problem going on, then definitely check for hemochromatosis. Then the other underlying causes of diabetes would be exogenous or endogenous steroids. So whenever steroids are given, which are given for a whole lot of reasons to different patients, for example, your COPD patients, your patients with autoimmune disorders, they are at very high risk for developing diabetes later on in life. So it's extremely important to not to be cognizant of that. That's why I use medicines very judiciously. Don't just give steroids for minor problems. How will these patients present? Of course, they will have sustained hyperglycemia, and then they of course have all the symptoms and signs of Cushing, which we'll talk about later. And then finally, some drugs can cause hyperglycemia, sustained hyperglycemia as well. So those need to be looked for too. They are not usually that they usually don't just result in overt diabetes, but can cause hyperglycemia. And if the patient is already borderline, then they will tip over to become diabetic. So for example, Seroquel, some of the psychotic drugs, and some of the even some of thiazide diuretics can cause hyperglycemia. So these are just some of the secondary causes of diabetes. Let's